Let's see, I want to just perhaps to briefly address the conflict question and the 1 death per 10,000. It's something that's been going on for a long time. I think, number one, it happened really, this 1 death per 10,000. Demographers hate it because that's not how you generally measure deaths to begin with. But basically it was a doubling of the baseline rate, and it was a doubling of the sub-Saharan African baseline rate of 0.5 10,000 per day. And the reason we used 10,000 per day was primarily because when you double it, you get 1, and in emergencies, it's easier to think in terms of 1, 2, and 3 as opposed to others. So there's no other reason than that. And if you look carefully at the first sphere said 1 death per 10,000. Secondly, the second one, and this one I was more involved in, is we just said that's only if you have no baseline rate. But if you have a baseline rate, double it. So if you look at Kosovo, if you look at we used UNICEF and other data to look at regions, because clearly sub-Saharan Africa has one of the highest death rates compared to Asia, compared to Europe. But I think even that is problematic, because if you look at Kosovo, for example, which was a classic one, there wasn't a tremendous amount of death in the outflowing. There was a lot of death during the conflict itself, a lot of due to violence. But afterwards, in Macedonia and the surrounding areas, there wasn't a significant increase in death rates. So we use numbers of deaths, but other people, and donors as well, will not necessarily use deaths to define when is it an acute emergency or not. So it gets even more complicated than that. And I would say in many situations, if you have a massive displacement, with or without death, that's an emergency, and we need to respond. And there have been numerous examples where that has occurred, where the death rate is not doubled, but it's clearly a humanitarian emergency. So these are things that we need to think about as well. I wanted to talk about urban settings, because for UNHCR, and me in particular, in the last while, I've been very much involved in the Iraqi refugee situation, dealing in Syria and in Jordan. And on top of that, some of us were involved in the Balkans, many of us probably in this room, and it's a completely different scenario. And so I wanted to talk about urban settings, and we will talk on Monday. Debbie published an article in The Lancet on Darfur, together with colleagues here, Olivia, etc., and we published one on looking at trying to set a new way of looking, a new framework for emergencies. And this relates to it because the framework that we're suggesting, well, number one is we're suggesting a lot of us are using, UNHCR certainly is using a much older way of responding to emergencies, which is primarily thinking camp-based situations in developing very, very low-income settings. And that's no longer the case, number one. So what we're suggesting in this article, and then this particular talk is going to focus on urban, is that we shouldn't be thinking in the linear frame. I think many of us know this as emergency, post-emergency, and then development or rehabilitation. We should really be, this is what we propose in the article, is to look at, number one, what is the setting. So is it camp-based? And there are fewer and fewer camps in the world now. Interestingly, in Haiti now, they're actually going to be making camps, massive camps, for a very limited period of time. But more and more, there are fewer camps in the world. So look at camp, look at urban, and then look at rural scattered. And rural scattered, we mean examples Eastern DRC or what's happening in Congo-Brazzaville right now. Number two, on the top column, on the top axis, look at low income, which is the classic that we can think of, Chad, Congo, and then look at more middle income. So look at Syria, Jordan, the Iraqi crisis, look at many of the displaced populations in India, in Chechnya, etc. So consider that, and then consider what you want to do, which sort of programs, and it's completely different. So that is in the Lancet article, and I think we will discuss this on Monday. What I want to talk about here, and because it's documentation, I'm focusing on the problems of documentation amongst urban settings. Because of my background, I may use refugees, but I don't mean refugees. I mean anyone affected by conflict. So if I say refugees, that's what I mean. And the other population that Debbie mentioned briefly is populations of concern is the term I'll use. And that means refugees, it means internally displaced persons, it means those affected by conflict that are not displaced, but it also means asylum seekers, stateless people, But it also means the surrounding host populations, whether they be surrounding for internally displaced persons or for refugees. So we need to really consider all of those people. So some of the key issues that I've spoken about is that classically we think of this low-income camp-like setting, and even though we can spout that we don't want parallel services, often that's exactly what we do. Is we end up having international NGOs, eventually it moves to local NGOs, and because the surrounding government services are so poor or non-existent, we set up parallel systems. In urban settings, we do nothing of the sort. Secondly, and this is why refugee situations, and I do mean refugees in camps, are often the easiest to deal with dealing with documentation, dealing with surveillance, and dealing with population-based surveys, because generally in these situations we have we have a census, not at the beginning, but very shortly afterwards. They're documented for protection purposes. So we have a decent denominator to deal with. Urban settings, we have nothing of the sort, which makes everything much more complicated. And same with rural scattered areas in eastern DRC. In Congo B, I don't know if any of you are following, but just in the last month and a half, 2 months, there have been over 17,000 people that have been displaced from Province Equator into Congo B, dispersed all along the river. Very, very difficult situation. And then the other thing that's really important, that's really been brought out in the Iraqi crisis, is in the Middle Eastern countries, they're like here for the most part, meaning you have a massive demographic and epidemiological shift. So you're not, of course, you're always concerned about under fives, but the most vulnerable populations are generally the elderly here from a public health point of view, and we're dealing with chronic diseases. And from a response point of view, it's much more expensive. You're dealing with chronic diseases, diabetes, hypertension, renal dialysis, cancers, and it's a whole game change of how you have to deal. And it's really complicated, but it also shows for the first time at least, and Gil Byrne and I were talking about this a couple hours ago, or an hour ago, is that you really have to link your documentation to cost. Because you can spend a limited amount of money on 3 or 4 patients, and you can not deal with another 100,000 patients when you're dealing with primary health care. So these are one of the areas this is one of the areas that we've been struggling with.